Right, so neurology. We're going to start neurology now. Okay, right. So a 60-year-old female, Bathsheba Everdeen, comes to you complaining of new onset unilateral headache for the past 3 days. Okay, so it's a new headache that's on one side of the head for the past 3 days. So again, remember guys, I said any pain, you would still technically do Socrates. A headache is still a pain. Okay, so just calm down. Remember, it's Socrates. Headache is still pain. Okay, so you want to ask again, was it sudden onset? Did it feel like someone hit you on the back of the head with a baseball bat? What's that? That's thunderclap, isn't it? That's subarachnoid hemorrhage, possibly. Okay, so you need to say, did it happen just out the blue suddenly? Did you feel like someone whacked you on the back of the head with a baseball bat? Or is it a headache that sort of came on and it was more insidious onset and gradual onset? Okay. And also, is the headache constantly there? Is it intermittent? Does it come and go? How often has it been happening to you? Because sometimes I have women who say, I've got a migraine probably 3 weeks out of the month, and it's starting to affect my work. So this woman in the management, it wouldn't just cut, it wouldn't just be enough. It wouldn't just cut it for me to give her sumatriptan and ask her to go on her way, because it's affecting her work. She's having a migraine for most days. Maybe at this point, yes, I would give her sumatriptan for the acute attack, but also maybe I need to consider prophylaxis as well. So how often it occurs is also important, okay? And don't forget, you can also get things like medication overuse headache. So if they've had a headache for a long time and they've been taking paracetamol, ibuprofen for more than 15 days of the month, or they've been taking sumatriptan for more than 10 days of the month, then this could actually be a medication overuse headache, and I actually need to not give them anything. So this is why asking them how often it occurs and what they've been doing for it is very important, because it affects the management, okay? And I'll just recap that again. So if someone has been taking loads of painkillers, so as I said, paracetamol, ibuprofen for more than 15 days of the month, or sumatriptan for more than 10 days of the month, this could be a medication overuse headache. So my management would be not giving them anything, telling them to wean off and stop everything, okay? If it's a migraine that is starting to be debilitating and is affecting this person's work, then giving them sumatriptan for the acute attack is not enough. I need to consider prophylactic as well, okay? So asking how often it occurs and what they've been doing for it is very important, okay? Again, Socrates, where is the headache? Is it here? Is it a band-like headache, so tension headache? Is it unilateral? Is it migraine? But unilateral could also be GCA. So asking about the location and the radiation, does it go anywhere, is very important, okay? Then you want to ask about the severity, the pattern, and the time. What does it mean? So for example, if someone says, I have the headache in the morning, I wake up with the headache. Well, this could be a space-occupying lesion. So it's very important, okay? Also, if they say, what? Okay, makes the headache better. That's a space-occupying lesion. If they say that that the headache comes when I'm on my periods, that means it's a menses-related pain. So maybe we can give them something that when their menses start will help with the headaches. So it's called mini triptan, or something like zolmitriptan, for example, can be very helpful in those who have a menses related headache. Okay, does it come with aura? So I say to them, can you tell when you're about to have the headache? This is synonymous with migraine. So I ask them, do you see something? Do you hear something? Do you smell something? Because it can be olfactory, it can be phonophobia. Sorry, they can have photophobia, they can have phonophobia. Okay, so can you tell that this migraine is coming on? Do you see something, hear something, smell something? Okay, is it associated with nausea and vomiting? Nausea and vomiting can be migraine, but it can also be space occupying lesion. Okay, because of the increased intracranial pressure. All right. Also ask them about rashes and fever and neck stiffness and photophobia, because that could be meningism. If it's GCA, right, guys, we don't call GCA giant cell arteritis anymore. We call it temporal arteritis, okay? That's what's accepted now these days, okay? But for us, because in our medical schools, we still go with GCA, but it's not there anymore. It's temporal arteritis, okay? So in temporal arteritis, is it that they have scalp tenderness? So is it an old lady saying, every time I comb my hair or I touch here, it's super sore, it's very tender, it's very sensitive? Or when I'm eating or when I'm brushing my teeth, or when I'm speaking and I'm moving my jaw, I'm getting a pain here in my jaw. Or I've started to lose my vision in my eye, obvious temporal arteritis, okay? So I'll tell you more about that in just a sec. There could also be some strange features, autonomic features. So for example, you might get a male who says that it doesn't happen very often, doc, but every 6 months or so, I get this severe searing pain on the one side of my head, and my eye starts to tear up, and I start to get discharge from my nose. That's a cluster headache. Okay, and usually they need oxygen and they need subcut triptan in that situation. Okay, so cluster headache. All right. Also, it can be associated with neurological symptoms. So now we're into a stroke. Whenever I have a headache, guys, I always rule out meningitis, stroke, GCA, subarachnoid hemorrhage. Those are the 4 big boys that you do not want to miss. Let me say that again. In headache, always temporal arteritis, GCA, meningitis, subarachnoid hemorrhage, and stroke, and sometimes space-occupying lesion. But because it's so few and far between, I only save it for the people who say, I wake up for the headache. Also, there's quite an important something that the patient can mention that is very important in history. Waking up with a headache is different to being awoken because of a headache. If someone is asleep and they're in deep sleep and they wake up because they start developing a headache, this is a major red flag. See, there's a subtle difference, but it's very important. To wake up with a headache, well, sometimes we can all wake up with headaches, and sometimes it can be space-occupying lesion. But to be awoken from sleep, to have your sleep disturbed because of a headache, that's a major red flag. Okay, that needs CT head to ensure it's not a space-occupying lesion. Okay. So the wording of your question is very important as well. Coming back to FAST or the stroke symptoms. So do you have weakness on one side of your face or body? I always ask them, do you have weakness on one side of your face or body? Has your speech changed? Okay, so slurred speech. Do you have any numbness or tingling or weakness on one side of the body? Okay. Also ask them, is there anyone else in the family who's unwell? Okay, so let me just go continue and then we'll go through differentials in detail. All right. So once you've asked Socrates, okay, you would then go into past medical history. Okay, so is there any immunocompromisation? Is there a malignancy? Anything that they should tell you about their past medical history? Any drug history? Okay, so as I said, most people, before they've come and seen the doctor about a headache, they have tried things, okay? They've tried Migraleave, they've tried paracetamol, they've tried Nurofen Extra. What is it that they've tried, okay? And also family history, because sometimes we do find that some families are just headachy. They just all have headaches and they all have migraines. So that's nice to know as well. All right. So what are the red flags? So again, severe sudden onset headache, so thunderclap headache, we're worried about subarachnoid. A progressively worsening headache may mean that the pressure in the brain is rising, okay? A headache that's associated with a trauma, so someone who's been in an RTA and has a headache or has had a ball to the head might be extradural, might be an intracranial bleed, okay? So that's a red flag. If they're starting to have meningism, red flag. Any loss of vision, so that could be temporal arteritis, but also if someone has an acute glaucoma, because we're going to do ophthalmology later, if someone has an acute glaucoma, so usually the scenario is Betty Davis went to watch a film in the cinema. She hadn't been there for a long time, and all of a sudden she's complaining of a severe headache. What's that? That's acute angle closure glaucoma. Okay, and why the cinema? Because her pupil has become dilated. Okay, because it's dark in the cinema. Okay, so her pupil has dilated, and so there was nowhere for that fluid to go. Okay, because the trabecula have become really, really condensed either side, and so they have this glaucoma. Come on, all right, and it's always that they were in a dark environment. Okay, that's usually how they write the case. And then you might also have neurological problems. So whether it's with the headache, it's associated, for example, with a very strange prodroma, not a typical prodroma, like you know, they might have a tingling or a numbness somewhere or something strange, okay? Or they might start to have a weakness in their body that again is atypical, not something like a stroke, but something different. Or they might, when they're having the headache, they might forget who they are, like go into a fugue state or something like that. Or they're having ringing and vertigo with it, that could be a sign for a cerebellar stroke, okay? So if they have tinnitus and they have room spinning with a headache, that could be a cerebellar stroke, okay? They might become ataxic, they might have nystagmus, they might have positive Romberg's, dysdiadochokinesis, past pointing, okay? So this could be a cerebellar stroke and needs to be addressed, okay? They might also be having faints with the headache. So that might be something cardiac. It might be something like an epilepsy, all right? So any weird neurological problem as well, you just want to touch upon it. But that will be covered when you ask the history, isn't it? Because you say, do you see something? Do you hear something? Can you tell when this is going to come on? No. Do you have any weakness in your body anywhere, or one side of your body or one side of your face? No. When you have the headache, have you found that it's affected your memory at all? No. Do you have any ringing or any room spinning with the headache? No. Have you ever fainted? No. Okay. Raised intracranial pressure. So what are the features? So vomiting, okay. Having a headache at night or being awoken up because of a headache. Finding that leaning forward relieves the headache, or finding that when you do Valsalva or straining brings the headache on. This can all be a sign of space occupying lesion. Okay. And then asking the past medical history. If there's a past medical history of cancer, what am I worried about here? I'm worried about brain metastases, that the cancer spread to the brain, is increasing the intracranial pressure, and is causing this headache. Okay. So how do we treat brain mets? So it depends on if it's one met, then sometimes we can excise. But obviously it depends where it is in the brain. But if it's brain mets and it's causing increased intracranial pressure, then possibly this is the end stage cancer anyway. So it's for palliation. But we can give steroids. We can give low dose dexamethasone tablet to bring the pressure down in the brain. Okay. This is not for the exam. This is just for your personal information. Okay. Also, if there's an immunocompromise, we worry about weird things in the brain, like cryptosporidium, for example, in the brain. Okay, so that's just why I mentioned the immunocompromise, something weird. And then, of course, if a pregnant lady comes in with a headache, you need to rule out preeclampsia. So you would do a blood pressure, you would make sure there's no proteins in her urine. We have a whole section on women's health, so don't worry, that will come later. Okay. Okay, so what are the psychosocial with the headache? Again, this is going to be the same thing said again and again and again throughout the course. It's things like, is it impacting work? Is it impacting the activities of daily living? Is there any alcohol or smoking or drugs involved? Whether it's affecting their life. So for example, the woman who has migraine has stopped going to work because it's happening so often. And also, is the headache getting them down? So I remember I had a patient who was 33 years old, male. He worked as a chartered surveyor. and he was having this headache out the blue. And we went through everything. We went through all the differentials, and in the end, it turned out he was just stressed. And, you know, it was like after weeks, like he'd been to two neurosurgeons, two neurologists. He tried all these medications. We even thought about the crazy weird stuff. We tested for it. He paid for it. And then in the end, it was just like, you're stressed. So we'll go through differentials now in just a sec. So in terms of examination of the headache patient, again, basic obs, they're the same, they're there. A neuro exam. So what I do with a neuro exam is I usually do, so I start off with the neurological examination. So I test sensation, I test power, I test reflexes. And with sensation, there's fine and gross touch, okay? Then I move on to cranial nerves. So usually I don't do a full cranial nerve, to be honest. I just ask them to shrug the shoulders and push down, ask them, you know, to push against their face, right and left, okay? And then I move on to ask them to stick their tongue out, you know, raise their eyebrows, blow up the face, okay? And then I move on to a fundoscopy. So obviously I'm just looking at the optic disc, making sure there's no pupil edema there. I look at the pupils, the pupillary reaction to light. And then I move on to cerebellar signs. So I do a bit of dystatokinesia. I do the pass pointing, so finger to nose, finger to my nose, a finger to my finger, and then I move the finger about. And then I do Romberg, so I ask them to stand up and close their eyes and make sure they're not falling over. Sometimes I do ask them to walk in tandem, so heel to toe, and making sure it's not a taxic gait. And then I do an ear exam as well, and that's it. That's me satisfied that neurologically they are normal, okay? You can do a mental state exam. I'm not sure if it's very relevant here. We will be talking about the MMSE in detail, so don't worry about that. But you know, you might want to do a mini mental if they're saying that it's affecting their cognition in any way, the headache. Okay. Then we can do ENT examination. So that is simply just to see if there's any signs of meningism. So obviously I'm referring to the neck movements here being restricted, okay, and whether there's any tenderness on the neck. And then in terms of investigations that you might want to consider in a neurological case, okay, so you might want to do inflammation markers. So that's your erythrocyte sedimentation rate, or ESR, and your C-reactive protein. You might want to consider CT and MRI. Remember, MRI is better for seeing the tissue, okay? But CT is good for seeing, you know, hemorrhages and things like that. Lumbar puncture, if you suspect that there is a subarachnoid hemorrhage or other infection in the CSF, and you want them to look at things like xanthochromia, okay? And also sometimes if someone has idiopathic intracranial hypertension, so, you know, obese lady with headaches and vision changes and pupil edema, goes to a doctor, we do a CT head, there's nothing on there, diagnosed with IIH. We can treat, first of all, lumbar puncture would tell us the opening pressure, so it can confirm an IIH, but also it can bring the pressure down as well via a lumbar puncture, okay? And then also we have temporal artery biopsy or ultrasound, and that is where you have a case of temporal arteritis or GCA. And what we do is we take a sample of the superficial temporal artery that's running along either temples, and we make sure we actually see the giant cells then. Some people, nowadays, they're not really doing the biopsies, to be honest. I think out of all the cases that have had GCA, one had a biopsy. Now what they're doing is they're doing the markers, and they're going off history, and they're doing an ultrasound scan of the artery to look at the inflammation of the artery. Okay. Something else I wanted to mention. If you suspect someone has temporal arteritis, but they haven't got vision issues, then we're talking about 40 milligram prednisolone or steroid daily, and then weaning off, okay? If someone has vision changes, then you're looking at starting at minimum 60 milligram to 100 daily and then weaning off. So 40 without and 60 plus with, okay?